Well, so it's a massive pleasure to welcome to Provoke Dr. Julia White, who works in Hyson Green, and she's going to talk to us about the deep end work, which I think is fascinating. Started, was it Glasgow, Julia? So to talk about that and health inequalities, and talk about that passion that you have.
Yeah. So thank you for coming. Thank you for the invite to do this. I am not a great public speaker, but it is something that I'm very passionate about. So hopefully that bit will get me through. So I'm just going to introduce myself, my background, my current job, my passions, then a bit about deep end groups, about health inequality, and about Nottingham. Then share a couple of stories, examples of patients where, things have gone well, and then finally a bit about social prescribing and where that's going and why I'm excited about that. Okay, so my name's Julia, Dr. White. I'm a GP in the Fairfields practice in Hyson Green. I've been there for 6 years. I work as a partner there. I'm originally from Bolton, did most of my training in Manchester, around the northwest, but came down to Nottingham 6 years ago. So my work passions are health inequality and lifestyle medicine. And my home life passions are basically running, open water swimming, crochet, pottery, go and see allotment, anything that gets me out and not thinking about work when I'm not in work. Okay, so deep end. Yeah, so the deep end project started in Glasgow. So it was a group of like-minded GPs who were working in practices with a lot of health inequality, a lot of deprivation, and they were concerned about the patients and the inverse care law. So if I click my, so they basically likened, used the analogy of patients who are in these deprived areas are like in the deep end of a swimming pool. So they're struggling, lots of things going on in life. Poor health could be one of those things. But really healthcare only really scratching the surface of their needs, and they're constantly just paddling away in this area. And they also use the same analogy to highlight the experience of practitioners working under the conditions of the inverse care law. So all of the deep end groups have sort of done their own little flag, and it all sort of represents, that's what the wavy lines are. It's that swimming pool, and then we've got our Nottingham colours, and you have to have you have to have Robin Hood on anything Nottingham, so he's there as well. So the inverse care law is those who most need medical care are least likely to receive it. And I mean, there's lots of reasons for this, and this is what is happening in the NHS. This has happened for many, many years, and there's lots of different reasons for it. So lower access to healthcare. So there's fewer GPs working in these areas, higher caseloads, sicker patients, underfunding for it. So I mean, I'm not going to go into how we're the funding really, but basically you're paid per patient, and then extra for additional healthcare needs. But traditionally that's been done on your age. Now in Hyson Green, your healthy life expectancy is 15 years less than in West Bridgford. So it can't just be on age, because then you don't get the funding for the work that needs to be done. And then you've also got things like you get pockets of extra money for hitting targets, and we get money for hitting smear targets. Now in our area, our nurses will work incredibly hard to get our women in to have their smear tests. We know that cancer rates are higher, but our women are first of all unable to take time off work, sometimes on 0-hour contracts. They'll lose their job if they take time off work, from countries where Smear tests are just not a thing. So you're starting from scratch with explaining why we want to do this invasive procedure. Quite often needing an interpreter alongside that. So you've already got somebody else needing to be in that room and trying to explain what's happening. And then if you've got a lot of other problems going on, your priority to go for your test is, it's not high up there on your priority list. So incredible amount of work goes into trying to encourage us hitting these targets. We don't hit the targets and we don't get paid for the work that has gone in the first place. So, that's also a problem in deep end practices. Patients just book an appointment, so you've got to have access to a phone line, internet, you've got to be able to speak the language. Temporary housing, so if you're in temporary accommodation and you're moved on after 3 months and you've got an appointment coming from the hospital that comes through in the post, then quite often you don't get an appointment for 3 months, especially at the moment, and you're not going to receive your appointment. And then there's all other factors that are not within the GP practice, like wealth, lifestyle, genetic, environmental factors. So their initial idea in Glasgow was to be a supportive group for each other and to be advocates for their patients. And there's now about 10 different groups around the country. There's one in Australia, there's one in Ireland. So about a year ago, our practice manager, who is also her passion is health inequality as well. And we're both huge podcast fans. Well, she listened to a podcast which someone was talking about the Deep End project. So we decided that we would like to set it up in Nottingham. And that's what we do. That's what we did. So I've got to say, yeah, the pandemic has helped our cause, really. Health inequality has become something that people are talking about. It is becoming something that the NHS is starting to recognise and start to do a little bit more for. So I've got to say it has helped our cause. Even though all the health inequality was already there beforehand, and it has become worse during the lockdown. So in Nottingham, we've got 15 practices who qualify as deep end practices. They're mainly Hyson Green, St Anne's, Bulwell and the Arboretum area. So we initially started, we just wanted to connect the GPs, the practice managers and nurses, anybody working in these practices to be a support for each other. And then try and get some actual things that would help us. So what we've managed to achieve in the last year is we've got a Trailblazer scheme going for fellowships. So this is newly trained, newly qualified GPs who are, so they're funded, they're paid, so they come into our practice, they enhance our workforce. So we've got an extra doctor now working within our practice. And they get 1 day a week dedicated to education about health inequality, able to do projects which are just looking at improving things within the practice, within the community. And that's been going now for about 3 months, and that's really, really exciting. We're working with the medical school. What you tend to get are better, well, not better, so practices that are able to have a bit of headspace and time to dedicate to education. They will have the medical students in, they will have the GP trainees in. And so you get what we want to happen is at the deep end practice to be able to support having medical students in. So the young doctors can see from an early point the benefits of working in these practices, and start that passion early and want to join practices and improve the workforce for the future. And then we want to build up with, so we want to connect the GP practices and the workforce within the GP practices, but then within the wider healthcare community, and then within the community as well. So it's just sort of, we want to connect everybody up, really, is the overall aims of it. And we are only a year down the line, and I feel like we've done quite a lot in this last year. It's been a lot of meetings, a lot of connecting people up, but it is only the start of it, and it's really exciting. So I thought then I would just talk to you about a couple of patients that sort of highlight sort of the difficulties and the joys within my job. So first one, patient A, so 28-year-old female, comes in every month for her chronic back pain, needs a fit note, needs to discuss pain relief. So after a few times of consulting with her, I was just, you know, we're not getting anywhere with this. We're not improving the pain. We're not, you know, we're not moving forward with it at all. And so then I'm building up a bit of rapport, a bit of trust with her. We're talking about what's really going on at home. What does she want to do for the future? You know, at 28 years old, I wouldn't want to be saying that I'm going to have settling for back pain for the rest of my life, and that's what I'm going to have. So I invited her to my running club that I'd started. So this was so I'm lucky enough to be on a Thursday night part of a running club in Woolerton, which is the most supportive group of women meeting up and running, not through lockdown, but and one of my friends there, we took the opportunity to solve the world problems every Thursday night and came up with the idea of doing a Couch to 5K for my patients. I'd regularly done park run and invited my patients to do park run, but often they would say, it's not really for me. There's too many people. I've never run before. It's very intimidating. I don't know what shoes to wear. I don't know what clothes to wear. I don't have any of the stuff. And so decided to start a little Couch to 5K group and invited a few patients to it. She came along, brought her son with her. I had help of a few really good friends who were also just wanted to get involved, and one of which was running with this girl regularly on the Tuesday night. And turns out she had always wanted to be a police officer. That's what she wanted to do. But she was stuck in that cycle of single mum, social housing, wondering whether to go on PIP for a back pain. You know, if you took a job, if you took some training, you get your money reduced. Can you afford to do that? It's a very vicious circle. She took a leap of faith, and she is 3 years into her police training now, and I do not see her at all in the surgery as a patient. So it went from seeing her fairly regularly to seeing her every week at the running club only, to her not needing any medication or fit notes or coming to see the GP. Yes, that's one of them. Second patient, so patient B, 18-year-old female. So I hadn't consulted with her before this first consultation, and this was after quite a serious suicide attempt that she'd had. And I was seeing her on a weekly basis. She was also under secondary care. She was waiting for counselling, CBT. Medicine was being given from secondary care, but there's often sort of weeks in between appointments. So I was keeping an eye on her weekly. Again, gaining trust with her, basically. Underlying issues, friends were going to university, she wasn't, unhappy with her appearance, her weight, didn't feel like she belonged anywhere. So I invited her to the running club. And also there was a fantastic, it's still going on, a fantastic group around the corner in Hyson Green, the Bike Works, which run a thing on a Tuesday where any adult with any mental health concerns can join. They give you a bike that needs fixing, they teach you bike mechanics, have lunch together, and then an afternoon out cycling. And persuaded her that this would be something great for her, but that initial go into it was her main, very anxious, very nervous about going to a new group. And I had 5 patients who I wanted to get involved with this group. I thought it would be beneficial for them. So I took my annual leave and went with them on that first day. And I mean, I learned how to fix my bike, which was an added bonus. But yeah, she joined, did the whole course there, came to the running club each Tuesday evening. And again, after I went from seeing her every week at the surgery to only seeing her on the Tuesday night out running, and then not needing to see her at all. And it was about 9 months down the line that she came back to see me. She booked an appointment, came back to see me to ask me if I would help her friend who was struggling with her mental health. But her friend lived in Birmingham, so I had to explain I couldn't be her GP in Nottingham, in Birmingham. But then when we broke it down, what I did was I didn't need to be a doctor to do that. That was anybody. She just needed some support. She just needed to know about a group, have some support to go to that group. And that was, and after talking about that, you know, we're saying like she could be that person for her friend, and and she said that was the thing that helped her more than the medication and the other side of it. So that was yeah. And this running group I would invite patients who I thought it would help, and I honestly didn't think that half of them would come. And they mainly did. Pretty much all of them came, and it was just patients who had never run before. I had one lady who I told the patient about it, and she was in my room with an interpreter, and the interpreter came to the running club from us talking about it, because she wanted to get involved. Yeah, so that's a couple of really good bits of my job that I get to do. And to be honest, it became like the best bit of the week. That work I was already doing in my GP surgery, but not very efficiently, not very effectively, and actually just took that time out onto the Forest Rec, which is conveniently close to my work. And yeah, it just became a lot more effective. Okay, so social prescribing. So yeah, really excited about social prescribing. It isn't something new. It's been going on in the community for forever. It's just about getting connections with people. But it is fairly new in that it's been formalised now into general practice. And this is the bit that I think has been missing, because, you know, patients come see their GP. It's a very privileged position in that you're able to give advice, and people take it with, you know, they will listen. And if you say, I think this will work, this will help you, then there's a little bit more oomph behind that if it's come from their doctor. And especially if you say, you know, I know the people, I know I will go with you, or I know. And so what I like that's happening is we're getting social prescribing into general practice now. So what I think's needed is they need to be part of the team. So I can say, we've got Angela, she's our social prescriber. She can, you know, she's here within our, she's part of our team. I want you to go and see her. She's got more time to go through what's needed for you and to support you, and get given time to physically go with people to join things. So I think it's a really exciting thing that it is now coming into general practice, and it's a skilled role. It's, you know, you've got to be able to talk to people and find out about build that trust, figure out what's important to them, their values, their aims, their limitations, and support them where needed. And then you've also got to be aware of everything going on in the local community and keeping up connections. It's a huge, and it's not just exercise. It's, you know, benefits, housing, loneliness, debt, domestic violence, carers. It's a huge job role, and I think it needs to be respected as a really important job role. And yeah, I'd love it. I'd love my patients to book an appointment and, you know, be booking straight in with the social prescriber, knowing that team is there and that support is there. And I think that's so the social prescribing is, you know, I'm excited about it now being connected up with general practice. It's always been there. It's always been something that people have just done, and, you know, great work in the community, and connections back into primary care is really positive. So I've got a couple of questions that I'm going to sort of pose and see. So how can the links between general practice and social prescribing and the community be improved? And then there's the second question is, has social prescribing become too medicalised by doing it this way? This is a question when I've discussed it with like medical colleagues, always brings up a lot of different opinions, and so I just thought that one would be quite interesting to see what people thought.